morning, good afternoon, good evening to all. Myself, Dr. Rahul Dubepuria. I am Associate Professor in the Department of Burns and Plastic Surgery at All India Institute of Medical Sciences, Bhopal, Madhya Pradesh. I welcome you all for the fourth episode of NOBBY podcast series. Today, I have a very dynamic Dr. Pawan Agrawal sir with me for the discussion. Sir is Professor and Head of the Department of Plastic Surgery at Netaji Subhash Chandra Bose Medical College, Jabalpur, Madhya Pradesh. Sir has a vast experience in the field of plastic surgery and he is an excellent academician with lots of publication under his name. With remarkable career dedicated to advancing the field of plastic surgery, Sir has been a key figure in both surgical practice and medical education. Dr. Pawan Agrawal sir's experience and dedication have earned him a huge respect among peers and students alike, making him a trusted educator and a leader in the field of plastic surgery. We are extremely grateful to have him with us today. Welcome, sir.
Thank you, Rahul. Thank you so much for the kind introduction. And as I believe today we are talking about the negative pressure therapy in the total burn management.
Yes,
So
sir.
I firmly believe that this negative pressure therapy is, is a very promising option and it is going to have a definite place in the armamentarium of a burn surgeon, maybe in future. And that's what this article says, like we will have some idea regarding the indication and the use of negative pressure therapy in the total burn care.
Yes, sir. So, as sir has already told about the topic for today's discussion is NPWT in burns, and we will be discussing a review article whose title is A Review of Negative Pressure Wound Therapy in the Management of Burn Wound, which was published in the Journal of Burns in the year 2016 by Contact et al. As we all know, NPWT stands for Negative Pressure Wound Therapy. In late 1980s, Dr. Luis Argenta and Dr. Michael Morequas, both professors of plastic surgery, developed NPWT at the University of Wake Forest, North Carolina, United States. In 1993, KCI, along with the University of Wake Forest, first described the commercial use of VAC, which is commonly known as vacuum-assisted closure therapy. So, to begin with the introduction, negative pressure has been employed in various aspects of burn care for almost 20 years, such as dressing for the acute burns, bridge to skin graft, securing skin graft and skin substitute as a dressing for skin graft donor site, as NPWT is also used as an integrated dressing for large burns. The aim of this study was to evaluate the literature on NPWT in the treatment of burn wounds. So, sir, can I ask what are the indications and contraindications of NPWT?
Yeah, correct, Rahul. As you can see in the slide, you already told about the indication. So
Yes.
the indication of negative pressure therapy involves the entire spectrum of acute burn care, right?
Yes.
From small dressing for a small acute burn, or maybe integrated dressing for the larger burn, which we
Yes.
will talk about later on. Then
Sure.
it can also be used to prepare the wound for grafting, that is the burn wound for grafting. It can also be used to secure your skin graft and dermal templates, and it can also be used as a dressing for the donor side after you
Yes.
harvest the skin graft. So
Yes.
entire spectrum of the burn care can be covered with this dressing. And if you talk about the contraindication, it is same as for the other wounds.
Yes, sir.
Like when you have a coagulopathy, when you have a necrotic tissue on the wound, when you have exposed vessel on the surface, which is prone to become prone for bleeding. So these are the common contraindication for negative pressure therapy for all kinds of wounds.
Yes, sir.
And at the same time, if you have a patient who is on anticoagulants, that's a related contraindication. You can still use the negative pressure therapy in these patients, provided they have the strict monitoring has been done.
Sure. So the methods which were used in the study, the PubMed Central and Cochrane Central databases were searched for articles before 2014 on NPWT as a dressing for acute burns, use of NPWT prior to skin grafting, NPWT as a booster for skin graft and dermal substitutes, NPWT as a dressing for skin graft donor sites, and NPWT as an integrated dressing for large burns. So the inclusion criteria was that the only studies which were performed on human subjects, which contain both an intervention group using a dressing with NPWT and a control group using a dressing without negative pressure were included. And the exclusion criteria was the individual case reports and case series which was lacking the control group and the articles which was not written in English. Coming on to the results of this study, overall 1,381 studies resulted from the search and only 15 studies met the inclusion criteria, out of which one study assessed the NPWT improved the perfusion in acute partial thickness burns. One study showed that NPWT improved the preparation for the wound for skin grafting. 8 of the 9 studies showed that NPWT benefits when it is used as a skin graft bolster dressing. One study showed that NPWT improved the rate of revascularization when it is used as a used for dermal substitute. One study showed that NPWT increased the rate. There is an increased rate of reepithelialization when NPWT is used over skin graft donor site. And 2 studies assess the benefit of NPWT as an integrated dressing for large burns. So, sir, what is the effectiveness of NPWT?
Yeah, Rahul, as such, the effectiveness of NPWT for the difficult wound has already been proved. Difficult wound means like a bed sore, diabetic foot ulcers, or maybe even for the post-traumatic difficult wounds. So it's already been. But using NPWT, especially in the burn wound, is recently a relatively newer indication. So it is quite feasible, and physiological principles are also seems to be quite sound. But we still have to have some more evidence before we can recommend it as a standard of care in burn dressings.
Okay. So there were different criteria which were used in this study. First was NPWT as a dressing for acute burns. A total of 147 studies, out of which 12 studies assessed the effects of NPWT on acute burn wounds, and only one study met the inclusion criteria, which compared the NPWT dressing with silver sulfadiazine with perfusion on each burn wound, which was measured by ICG video angiography. And in this study, NPWT results in preservation of perfusion in the injured tissue in first 3 days after injury compared to the controls. Second criteria was NPWT as a bridge to skin graft. A total of 283 studies, out of which 22 studies assessed the NPWT as a bridge to skin graft, and only one study met the inclusion criteria. And this study was not done on a burn wound, it was done on a traumatic wound. And it showed that pre-treatment with NPWT showed improved total graft take, decreased need for regrafting, and shorter duration of hospital stay than the controls. The third criteria was NPWT as a booster dressing for autograft. A total of 283 studies, of which 47 assessed the effects of NPWT when used as a booster dressing for fresh autograft, and 9 studies were met our inclusion criteria. So 8 of the 9 studies shows improved outcomes in NPWT group with significantly lower rates of graft loss, lower rate of repeat grafting procedure, and lower hospital stay. Another criteria was NPWT as a dressing for integration of dermal substitute. A total of 44 studies, out of which 27 studies assessed the effects of NPWT when used as a dressing over dermal substitute, and only 2 studies met our inclusion criteria. One study showed decreased time to revascularize of dermal substitute as well as improved adherence of skin graft over the dermal substitute. Second study showed improved long-term scar elasticity in the dermal substitute group when NPWT was used comparing the conventional dressing. Another criteria was NPWT as a skin graft donor site dressing. A total of 21 studies assessed the effects of NPWT on skin graft donor sites, and only one study met the inclusion criteria. In this study of 10 patients who had 2 donor sites, thus served as their own controls, and it was observed that the rates of reepithelialization were compared in the NPWT groups versus controls and determined by pulse biopsy. And NPWT treated site shows faster reepithelialization in this group. Another criteria was NPWT as an integrated dressing for large burns. A total of 23 studies resulted from our search, and out of which 2 studies examined use of NPWT for large total body surface area. Neither of these studies met the inclusion criteria. However, they are both referenced in the discussion. So coming on to the discussion, uh, NPWT provides a moist environment for wound healing, prevent the infection, reduces the inflammatory mediators and progression of the burn wound. So it is a very handy therapy which can be used for treatment of the wounds. The purpose of this review is to examine the existing clinical evidence of various potential uses for the NPWT in acute burns. The study has confirmed that the NPWT treated wounds exhibit improved perfusion of the injured skin, decreased edema, decreased bacterial count, and a reduced need for skin grafting. And NPWT also leads to less frequent dressing. So, sir, can I ask what is the mechanism of action of NPWT?
Yeah, the negative pressure wound therapy works through various mechanisms. The first and the most important thing that it increases the microcirculation of the wound.
Sir, how does it
It also,
increases the microcirculation?
yeah, it basically what happens when you apply a negative pressure therapy, it causes micro deformation of the cells, and it
Yes.
also causes compression of the tissue beneath the foam dressing. This compression causes hypoxia in the wound, and this hypoxia leads to angiogenesis. At the same time, there is a vasodilatation because of release of nitric oxide. So this mechanism, by this mechanism, it increases the microcirculation. Other mechanism like it also causes increased rate of growth of the granulation tissue. It reduces the bacterial count. It reduces the edema. It regularizes the inflammatory response and stabilizes the wound. So by all this mechanism, it makes the wound better and makes it heal faster and makes it suitable for the reconstructive surgeries much earlier.
Okay. And what is the optimal negative pressure used in NPWT?
If you see the negative pressure that range from minus 25 to minus 500 millimeter of mercury.
Yes, sir.
So if you use the minus 25, that is a low pressure that causes a minimal deformation of cell and there is a minimal increase in the blood flow. And again, granulation tissue growth will also be very, very less. But if you use the higher pressure like minus 500 millimeter of mercury, that basically distort the tissue, causes lots of hypoxia in the tissue, and as such, there's no blood flow in the tissue and no growth of granulation tissue.
Okay.
So both the extremes are bad. So the optimum pressure is still minus 125 millimeter of mercury. But again, there's a caveat to this rule, like you have to adjust the pressure depending upon the wound. So if you have a chronic wound, then maybe minus 50 millimeter of mercury is a good pressure. And if you have a good optimal wound, then minus 125 millimeter of mercury pressure in a intermittent mode would be best.
Yes. So, sir, one more question comes in my mind that what is intermittent versus continuous vac? Any
Yeah.
concept or
If
any
you
thought on
see,
this, sir?
yes, correct. So we can use both the modes, but most of the study which suggest that if you use the intermittent mode, what happens during the vacuum off phase, when there is no pressure in intermittent mode, there is a maximum blood flow and maximum generation of the granulation tissue in a vacuum off phase. So obviously intermittent mode is definitely better than the continuous mode.
Yes,
So
sir.
it's always better to use intermittent mode.
Okay. So one criteria was management of acute burn wounds with NPWT, and there was weak evidence in favor of NPWT for the management of acute burn wounds. So, sir, what are the possible complication when NPWT is applied over acute burns?
It is same like for the other wounds also. Like
Okay,
if
sir.
you see the complication, first thing would be related to the VAC system or NPWT system. So there may be failure of power, there may be blockage of the tubes, there may be breakage of the seal. So the vacuum doesn't form, and there may be allergic reaction to the adhesive tape. So these are the complications related to the VAC system. And there are certain wound related complications also. Like if you have used VAC on a not really a suitable wound for the VAC, like when there's a necrotic tissue or maybe exposed vessels, then there may be excessive bleeding, and wound may deteriorate and may lead to excessive infection also and increasing pain. Apart from these two major complication, the other thing is that patient is mobility is restricted because of the VAC machine,
Yes, sir.
and maybe there's a poor patient compliances due to that. So these are the in general the complications related to the VAC system.
Okay. Another criteria was NPWT for the preparation of burn wound for skin grafting, and there was a weak evidence in favor of NPWT for preparing the burn wound for skin grafting. So, sir, can I ask what is your experience of NPWT in preparation of burn wound for skin grafting prior to the skin grafting?
Correct. So, I mean, this is the most common indication we are using the VAC for burn patients. Like we are very happy with the donor side dressing. We don't have to open for 3 weeks, and that
Yes, sir.
usually heals normally.
Yes, sir.
But preparing the burn wound is very difficult. It is different from the traumatic wound, which gets
Definitely.
better within no period. But once you debride, you see lots of fat get exposed, yellow fat get exposed, lot of dirty granulation tissue get exposed. So preparing the burn wound is definitely a challenge, and NPWT definitely helps in that. And the basic mechanism probably which I understand is that it causes increase in the granulation tissue formation. So that is one thing. Secondly, it also reduces the depth and the volume of the wound. So both
Okay.
the thing, maybe wound contraction as well as increased rate of granulation tissue might be responsible for early preparation of the wound for the grafting in
Okay,
case
sir.
of burn with the NPWT therapy. That is my take.
Okay. So, the most important criteria was NPWT as bolstered dressing for graft. And there was a strong evidence in favor of NPWT as a booster dressing for graft. And this slide is the most important in this discussion, as NPWT reduces the accumulation of seroma and hematoma. It closely opposes the graft and the bed. NPWT reduces the shear forces on the graft. It decreases the graft failure and regrafting rate. And there is always less hospital stay and there is less financial burden on the patient. So, sir, can I ask what are the general precautions we should take while applying the VAC therapy or NPWT?
As such, the method of application of VAC is a quite standard one. But
Yes,
one
sir.
thing, one complication which you have to reduce or we have to avoid is basically the air leak. Whenever there is a break in the seal, vacuum seal, and the air get leaked into the wound, there is a continuous flow of the air over the wound surface that causes lots of desiccation of the wound and a scar formation. And below the scar, wound will deteriorate, lead to severe infection, maybe bleeding and increasing pain. So air leak should be avoided at any cost in the
Yes.
vac management. That's the most important complication you should avoid.
Okay, sir. Another criteria was NPWT as a dressing for integration of the dermal substitute. Uh, After analyzing the studies, no conclusion can be drawn about using NPWT to revascularize the dermal substitute to burn wounds beds. NPWT is a skin graft donor site dressing. There was weak recommendation for NPWT as a dressing for skin graft donor sites. So, sir, what is the problem in using NPWT as skin graft donor site dressing
Yeah,
in
because
burns?
what happens, like as the study also suggests, it reduces the reepithelialization time. That's a great benefit in case of major burns, because you again want to harvest the graft from the same donor site,
Yes, sir.
because you are always short of the autograft in these patients. So that thing is sure, it reduces the reepithelialization time. But if you compare it to the conventional dressing where we don't change the dressing,
Yes, sir.
here, the NPWT negative pressure therapy dressing has to be changed maybe third or fourth day. So the repeated change of the dressing and the cost has to be considered before we recommend this negative pressure therapy on the donor site.
Okay, sir. The last uh, criteria was NPWT as an integrated dressing for large burns. It is feasible and in initial report is promising. The idea of creating an integrated total body dressing using NPWT was first proposed by Chong et al. And it is a method known as total body wrap, in which a sandwiching limbs in large polyurethane dressing with a thin strip of sponge placed in dependent position is done. This concept takes advantage of ability of NPWT to secure skin grafts and promotes reepithelialization in skin graft donor site while removing inflammatory exudates. And by examining this study, it is generally not recommended and this is not supported by good evidence and furthermore their cost effectiveness is also unknown. So sir, can I ask what are the red flag signs during NPWT?
Uh, if you after putting a negative pressure therapy, if you see there is excessive bleeding in the canister,
Yes, sir.
when there is a foul smelling discharge, Or
Yes,
if you
sir.
see peri-wound cellulitis or cellulitis around the dressing, or maybe there is an increasing pain, or there is a systemic sign of sepsis like high fever, high TLC count, and patient looking toxic. So all these are the red flag signs. You have to immediately terminate the negative pressure dressing and start with the conventional dressing with lots of local antibiotic and systemic antibiotics.
Okay, sir. So to conclude, negative pressure can improve autograft take by limiting inflammatory injury and promoting preparation of a wound bed in acute burns. But there is limited data to suggest that it may also improve the rate of revascularization of dermal substitute and promote repolarization of skin graft donor sites. Integrated dressing for the management of large wound are also not supported by good evidence. Thus, NPWT holds promise in acute burn management. However, indication, complication, and cost analysis are warranted to establish negative pressure as an effective agent in burn wound care. So we come to the end of this podcast. Thank you so much, sir, for your valuable time and gracing the overall occasion with your kind presence, sir.
Thank you so much, Rahul. Thank you. I really enjoyed this.
Thank you, sir. Thank you.
Thank you.